नमस्कार फ्रेंड्स। आई होप आप लोगों को मेरे पुराने वीडियोस काफ़ी पसंद आए। मुझे पता है वो वीडियोस खाली इंट्रोडक्टरी वीडियोस थे, और आप ही के सजेशंस और फीडबैक को देखते हुए मैंने आज इंग्वाइनल हर्निया की एनाटॉमी और सर्जिकल स्टेप्स डिस्कस करे, और शायद आप लोगों को पसंद आए। तो मैं आपके कमेंट्स और फीडबैक की वेट करूँगा। To know the anatomy of inguinal region, we have to understand the layers of inguinal region. Suppose this is the anterior abdominal wall. First layer is skin. We have to draw an imaginary line from anterior superior spine to pubic tubercle. That forms inguinal region or groin. From inguinal region to scrotum, that is called inguinal scrotum region. Below skin, there is fat, subcutaneous fascia. Then comes external oblique aponeurosis. You have to identify the aponeurosis by the direction of the fibers. The external oblique insert in the direction when you insert your hands in your front pockets of the trouser. This is the reflected part of the inguinal ligament, external oblique aponeurosis, that is inguinal ligament, and this is a obtuse angle opening in the external oblique aponeurosis. This is superficial ring. As soon as external oblique aponeurosis is open, we are encountered with the inguinal canal extended from the deep ring to the superficial ring. The contents of the canal, as you can see, sac, cord, and lots of other structures like nerve, arteries, veins. Deep ring is a circular opening in the fascia transversalis. These are internal oblique aponeurosis fiber. These are just opposite to external oblique aponeurosis fiber. You have to put your hand in the back pockets of your trouser. This is conjoint tendon formed by fibers of internal oblique aponeurosis and transversalis muscle. Structures in the spermatic cord: vas deferens, testicular artery, artery to the vas deferens, artery to the cremaster, pampiniform plexus, nerve genital branch of genitofemoral, ilioinguinal nerve, and these whole structures are covered by external spermatic fascia, cremastic muscle, and internal spermatic fascia. What are the routine investigations done to prepare patient for surgery of inguinal hernia? We have to do CBC with platelet count to know hemoglobin level and platelet count of the patient. PT-INR for coagulation profile, blood sugar if patient is diabetic or non-diabetic, KFT for kidney function test, triple viral marker HIV, HCV and BSEG, chest X-ray in PA view to see any lungs pathology, ECG to rule out heart disease, urine routine microscopy to see any kidney disease or kidney infection, and most important is ultrasonography to see prostate size and post void residual urine. And this investigation doesn't rule out importance of a good rectal examination. So these are the investigation we do for preparation of inguinal hernia cases. Now friends, when we are gone through surgical anatomy of inguinal region, now let's see stepwise layers of inguinal region and how we dissect sac and cord structures, and what are the other steps of the surgery. A skin incision is made parallel to line joining anterior superior iliac spine and pubic tubercle. After encountering epidermis, dermis, subcutaneous fat, deep fascia, then comes fibers of external oblique, and you can see direction of external oblique fibers are downwards and inwards. After identifying fibers, just make a incision parallel to the skin incision. After opening external oblique epidermis, you have to identify cord structures and sac. Start dissecting from the pubic tubercle. Put your finger and anchor both cord and sac. After dissecting external spermatic fascia, cremastic muscle, internal spermatic fascia, we came across sac with cord. Gently separate cord from the sac, and sac is separated till deep ring. Empty the sac and rotate it clockwise after ensuring there is no content, or we can open the mouth of the sac also to see the structure. After ensuring emptiness of the sac, transfix the sac and divide and reduce the content, and repair the incision in layers. Closure of wound we can do in 2 layers, closing deep fascia, external epidermis, and skin by stapler or skin sutures. While dissecting through inguinal canal, we have to save arteries, vas deferens, nerves like genital branch of genitofemoral and inguinal nerve. The steps shown in this particular procedure had operated sac till deep ring, and this is indirect inguinal hernia, and we are operating on a right side. Here this medial side is bounded by rectus sheath, and inferior epigastric artery forms Hasselbalch triangle. If we are lateral to the inferior epigastric artery, then this is indirect hernia. If we are medial to the inferior epigastric artery, then this is direct hernia. Here we can feel femoral artery, femoral vessels also. Deep ring is just above the mid-inguinal point. Now again we will revise how to define the hernias. Let's take right-sided inguinal hernia. First, consider inferior epigastric artery, right inferior epigastric artery. If we found sac lateral to the inferior epigastric artery, then this is indirect, and that's coming from the deep ring. And if sac is medial to the inferior epigastric artery, then this is a direct inguinal hernia, and defect is in the posterior wall. What are the possible managements available? In cases of congenital hernia, we have to do herniatomies. In cases of adult, we have to do mesh repair by open or laparoscopic method. There are certain precautions to prevent complications. There can be injury to vas deferens, there can be injury to nerve, genital branch of genitofemoral or nerve inguinal. We have to do hemostasis to prevent seroma formation, which ultimately lead to infection and other complications. तो मैं आपके कमेंट्स और फीडबैक की वेट करूँगा. Thanks for liking and sharing and subscribe.